So colleagues, welcome, good morning, good afternoon, good evening. My name is Laura Fitzgerald. I'm a senior program advisor with JPIGO, and it's really my pleasure today to be with Dr. Wanyaro and all of you to discuss the virtual mentor. If I could please just take a moment to introduce our presenter, Dr. Wanyaro. He is an associate professor of obstetrics and gynecology at the School of Medicine at Kenyatta University. He has more than 25 years of experience delivering healthcare in Kenya, and he holds a master's degree in obstetrics and gynecology from the University of Nairobi and a PhD in epidemiology from Kenyatta University. He's been involved in several research projects related to maternal and neonatal healthcare, most recently the Preterm Birth Initiative in Kenya. He's widely published, and along with colleagues from the University of California at San Francisco, he's currently working on an innovation for postpartum hemorrhage, which is the subject of today's presentation. Colleagues, we're gonna have an opportunity to hear Dr. Wanyaro present about the virtual mentor. He's going to demo it a little bit for us, and then we'll protect some time, hopefully at least 15 minutes or so for Q&A at the end. So please do put your questions and comments in the chat box or the Q&A box, and we'll be sure to get to them. Dr. Wanyaro, over to you.
Thank you, Laura. Colleagues, good morning, good afternoon, good evening. I'm going to present on the virtual mentor, which is a virtual assistant for healthcare workers at the front line of healthcare. Now, this is our team, myself from Kenyatta University, Tiffany, Dillis, and Hannah, who are from UCSF, and some of them are with us today, and they can also help in answering some of the questions. Now, over the last 3 days, we have heard a lot about nurses and midwives being the one who conduct most of the deliveries in resource-constrained settings. And when they do these deliveries, oftentimes they are alone. Of course, they are also the people or the healthcare workers who are likely to encounter complications such as PPH. We have resources that have been put in place to help healthcare workers to manage complications, such as printed wall charts, as you see in the PPH protocol. But unfortunately, these resources require manual manipulation, and they may be of little or no use to workers when they need both hands, especially in obstetric emergencies such as PPH. So, to manage patients properly and to improve the quality of care, health workers need easily usable decision support tools so that they can be able to implement treatment protocols, such as the PPH protocol. Now, this is exactly what the virtual mentor aims to do. And we want the virtual mentor to help providers to effectively manage situations such as PPH every time it occurs. Of course, being a community of practitioners, you know why we chose PPH, but in brief, we know that PPH is the commonest complication that the midwives are likely to encounter. It is also a complication that when the right steps are taken, then the mother's chance are improved. So what we did is that we took the PPH management protocol and programmed it into a dynamic branching algorithm, which can be used either as an offline or an online application. And this device engages health providers in a guided spoken conversation. What you are seeing, the two images that you are seeing on this slide, with the one on the left side of the screen is an example of the branching logic. And the one on the right side is the providers with one of my colleagues going through the steps of making the device. Now, this is a simulation training session for PPH, but I want us to imagine for a moment that this is a real situation, where this midwife is being guided by the virtual mentor, which is circled here. The virtual mentor is basically a voice-activated, hands-free computer voice device that is supposed to break the paralysis of indecision, allowing the provider to use both her hands in managing the patient. It integrates the algorithms into text-to-speech software and can be used in any Android device. To demonstrate how the virtual mentor works, I want us to imagine Tiffany as a midwife who has just delivered a mother who starts to bleed profusely. Of course, like all many people do, she panics, but suddenly she remembers that she has the virtual mentor and shouts,
"Help."
Hello, I am Malaika. Would you like my assistance with postpartum bleeding?
"Yes."
What is your name?
"Tiffany."
Tiffany. All will be well. Is the mother conscious?
"Yes."
I am here to help you and the mother. Tell the mother I'm here to remind you of all the correct actions to stop her bleeding. Shout for another person to assist you. And then say, next.
"Next."
Fix 40 units of syntocinon IV and let it flow quickly. Remember that the maximum dose of syntocinon in 24 hours is 80 units. Massage the mother's uterus. Empty the bladder. When you are done, say, next.
"Next."
Well done. Is the mother still bleeding?
"Yes."
Check the IV fluid is running. Now look for bleeding vaginal or cervical tears. Are there bleeding tears?
"No."
Did the mother give birth within the past 3 hours?
"Yes."
Give tranexamic acid 1 gram IV over 10 to 15 minutes. When you have done this, say next.
"Next."
This mother needs IV fluid replacement over the next 24 hours equal in 3 times the amount of blood lost. Consider blood transfusion. Check vital signs every 50 minutes. Update your notes. To hear the final message from me, your virtual mentor, say next.
"Next."
Take a deep breath. Remember to debrief. Ask yourselves what went well, what did not go well, and what you will do differently next time. Replace supplies. This is the end of Virtual Mentor's PPH protocol. Virtual Mentor will stop assistance now.
So colleagues, that is the virtual mentor. It puts life into the PPH protocol in a way that a conversation can be held between the midwife and the virtual mentor to allow her to be able to take step-by-step management of a patient with PPH. We started developing the first prototype late last year, and by February of this year, we were able to test the prototype with 16 midwives drawn from 4 health facilities in Kenya. The midwives had experience from as low as 1 year all the way to over 20 years. We assessed the midwives' knowledge and confidence in PPH before and after interacting with the virtual mentor during simulation training of PPH. We also assess for their user experience with the virtual mentor. All this, as I have said, was done through simulation, using pronto simulation principles. We took their input that they gave in February and further developed the prototype into Virtual Mentor version 2.0. And this we have just managed to do still further testing with the same midwives in June 2020. Now, this slide shows the change in PPH knowledge after a single use of the Virtual Mentor. And as you can see, despite years of experience of the midwife, the knowledge is usually not 100%, and more so in the correct infusion for tranexamic acid, and also the volume replacement, as well as the route of administration of misoprostol. But what we see across board is that the knowledge increased significantly after a single use of the Virtual Mentor. Of course, confidence is key in management of situations such as a PPH. And when this confidence is lacking, as you can see here, then of course the quality of care also is affected. But as you can see, after just one single use of the Virtual Mentor, the confidence level across board increased tremendously. And what is shown in the far right of my screen is an increase from 50% to 100% in being capable of effectively managing postpartum bleeding. You can develop a solution, and if the user experience and if the user feels that the solution is not very helpful, then that solution is as good as dead. This slide here shows how the 16 midwives felt on whether the Virtual Mentor can be useful to them in real life patient care. And all of them indicated that they had a strong confidence that the Virtual Mentor could be useful in real patient care. To put this into perspective, I'll just give a few quotes of feedback from the midwives. And the first one, they said that it is systematic in the way it explains the steps. And they recognize that in emergencies, because of the anxieties associated with emergencies, they tend to forget the steps to take. They may know the steps, but they tend to forget. But when the Virtual Mentor was explaining the steps, they felt the confidence and they felt that they were doing right. In this one, they talked about feeling calm, despite the situation of PPH, that the Virtual Mentor made them feel calm, and especially in situations where they have no senior person to look up to help them in reminding them the steps to take. Finally, they also felt that when they have an emergency such as a PPH, that they need somebody who they can feel they are talking to, and somebody who is listening to them and giving them the right steps of taking care of this patient. And they felt that this is what the Virtual Mentor was doing during the simulation training. Now, what are our next steps? One, we want to continue doing simulation testing. We want to continue testing the Virtual Mentor in simulation training. And we have a good chance in Madagascar, but because of the COVID situation, this has been delayed. And any of us who is doing simulation training for PPH can feel free to partner with us. The next thing is to explore opportunity to use the virtual mentor in existing in-service training programs, like what happens in the medical training service, and anybody who is doing training in these colleges can also partner with us. We are also raising funds for a clinical care pilot to assess the feasibility and usability of this solution in real patient care using midwives in 2 counties in Kenya. And this will be followed by an effectiveness study, which will be a randomized controlled trial. Of course, our ultimate goal, and this is something that also the midwives have requested, is that we should build the virtual mentor for other clinical conditions, adapt the virtual mentor for other complications, such as pre-eclampsia and eclampsia, where they also forget the steps and the dosages, how to manage things like shoulder dystocia, and also something like neonatal resuscitation, which they also feel that they may need to be taken through the steps. Thank you.
Thank you so much, Dr. Wanyoro, for that introduction to this innovation. I know that my colleagues will agree with me that this is really exciting. We're seeing a number of questions coming in through the Q&A box, so I'll read those out to you in the order that they came, okay? We've got about 15 minutes for Q&A. Dr. Wanyoro, there was one question that the algorithm on the slide, the printing was quite small, so it was hard for folks to see it. Can you speak to what's included in that algorithm and maybe a little bit about the development?
Okay, thank you. The algorithm, it was a bit small, but it was just an image. But what it involves is that we took the PPH protocol and looked at the scenarios and the various scenarios that a PPH might arborize into. And for this branching logic, you start with the mother who is bleeding. Then you look at the mother, whether she is conscious, just the way you would assess whether she is conscious or not. And if she is not conscious, then it will take you through the ABC of managing the mother who is unconscious. Then it will take you, ask you after that, we remind you to fix IV fluids, okay, and then massage the uterus, etc., up all the way to the end. Then if the mother is conscious, of course, the next thing is that it will ask you the mother's name, and you assure the mother that we are going to help the mother to the condition, and she's going to be well. Then it will take you the various branches that you might have to manage in a woman who is bleeding after delivery.
Thank you so much. That kind of takes us to our next question, which is how is this being developed for the different causes of PPH? So how it's attending to the specific case of that woman, given that there are different causes of PPH, and how is this being orchestrated with the emergency drill team?
Well, thank you. How it is factoring is that, one, after it will look at, of course, there are steps that you must take that are general for a PPH mother. And there are also steps that you must take for specific conditions that are causing a PPH. So imagine that woman who is bleeding. Of course, the first thing is to resuscitate the mother if she has bled a lot. You put the IV lines, take the specimens, then you ensure that the fluid, the intravascular space is taken care of. Then if you are alone, of course, you go to the pelvis and start massaging the uterus and insert the catheter. So it takes you, it is not developing a new algorithm. It is taking the algorithm that we have, the protocol that we have for PPH, but now putting it into a conversation, but allowing you to skip. Like if you are asked to check for vaginal tears, then it will ask you whether the mother has vulvovaginal tears, and it will instruct you if there is vulvovaginal tears, then you repair them. Then if there are no tears, then it will ask you whether there is the uterus is contracted or not. If you say it is not contracted, then it will give you instruction to massage the uterus and to give a uterotonic agent. If it is well contracted, then you say yes, it is contracted, then it will take you to the next level. So it is able to recognize your answers because you are conversing with it, it is asking you a question, and when you say no, it will take you to a different branch or logic, etc. If you say yes, then it will help you to manage that condition as it had asked you.
Thank you for that. Okay, next question is around pairing the device with emergency or PPH training. And the question is, I understand Pronto training was used. Was the pre-knowledge and confidence assessed before the Pronto training or after the training, but before exposure to the virtual mentor?
That's a good question. So the Pronto simulation training module is what we actually used to test, but we were not training the midwives on PPH. So we use the Pronto simulation, including their equipment, to be able to simulate a PPH. So all we were doing is using the module for PPH, what they use to train midwives on PPH, but we were not training the midwives at that level. We were just using the equipment they use. Yeah.
Like the simulator.
Yeah.
Okay, that's helpful. Thank you for clarifying that. We also have several questions around the technology and the requirements. So questions about what kind of technology or gadgets are needed and the cost, as well as requirements around internet connectivity.
Okay, so thank you. That's a good question. So I'll start with the internet connectivity. So recognizing that many of our facilities do not have internet connectivity, we have developed an application that can be uploaded or downloaded into any mobile phone, which every midwife in Kenya, or most of our midwives, are having. And the only time they will need internet is to download the application into their mobile phone. After that, they don't need to use the internet. So they can use this, and the usefulness of it is that they can put it in their pocket, and as the midwife is working maybe in a postnatal ward and they realize a patient is bleeding, they just need to say help, and then the device will start having a conversation with her on the management of that patient. Of course, we also have the tablet version, which is basically online, and this version, we see it as being mounted on the wall in the delivery rooms for facilities that have internet, or they can be able to have dedicated internet connectivity specifically for such a device. So this will have a big screen which will be mounted in the delivery room, and this will be internet connected. So we have the two versions to cater for the two situations.
Okay.
Of course, the cost the cost of the main cost goes to the development of the solution. After that, the hardware, which is basically the mobile phones or a tablet, may not be that expensive, because any mobile phone that is using Android can be able to use this device.
Okay, so it sounds like there are some kind of higher and lower expense options depending on the situation.
Exactly.
In terms of hardware. Thanks for clarifying that. A couple of issues that came up in the last session that I think might be helpful for folks to learn about as well. We had some questions about adapting for language as well as adapting for specific national guidelines. Could you please speak to that a little bit?
Yeah, the solution is very versatile, and it can be able to adapt to language. Right now, as we are speaking, we are adapting it to the language spoken in Madagascar, which is very different because they don't speak in English. So we are trying to adapt, we are adapting it to their language and also to the national guideline for Madagascar, which is slightly different from our guideline. So all we need is to take the guideline and build branching logics on the guideline so that it can be now uploaded into the software. So this is done at the back end, and then it is just uploaded. And that's why we are saying in our next version, we'll even add more complications like shoulder dystocia, eclampsia, and protocols for neonatal resuscitation, which you agree, you find that these protocols are all over. We have the protocols which are well printed, but most of us or most of the midwives do not get time, especially with this even increased hospital deliveries, which are occurring now. They don't get time even to peruse through that protocol. And also, even looking at the award chart is also very hard, especially in that moment when that woman starts to pour. So you need something that you can quickly activate, and it is easily usable.
Thank you for that. I think we've got maybe a couple more questions from this group before we wrap up. One question from a colleague in Nepal: what happens if the PPH is not controlled by first-line management? Will the virtual mentor guide for refractory PPH as well?
Well, the virtual mentor recognizes that sometimes you may not be able to have the resources to manage the PPH. So you may not have a drug, or you may not have an equipment like anti-shock garment, and it allows you to skip. It will ask you if there is need for a virtual mentor, for an anti-shock garment to be put on the patient. Then it will ask you, do you have an anti-shock garment? Then if you say no, then it will take you to the next step. If you say yes, then it will ask you whether you need assistance to be able to put the anti-shock garment. And then it will give you the steps on how to put the anti-shock garments, starting with 1 all the way up to 6. It recognizes that situations may arise when the PPH does not stop, and you need to take the patient to theater. So when the patient is still bleeding, even after you do, like your patient is especially when the patient is unconscious, or you cannot recognize, or you cannot be able to take care of that patient, then it will tell you to call the next person or your senior, or inform the next level of care, the next hospital, because this is something that we also miss. And it also tells you that you ensure that you take the specimen that you had taken and refer the patient with the specimen. So you have already informed the second care level of care, and you also have, you take the patient with the specimen. It will also instruct you if you are referring, then you can apply aortic pressure as you refer the patient. So it takes you all the way to when you hand over the patient to the next level, and especially to theater.
Very, very comprehensive. Thank you so much, Dr. Wanyoro. It's about time to wrap up with this second breakout session. We do have a request from one of our participants saying, please include maternal resuscitation as you're developing your suite of virtual mentorship modules. This is really fantastic. Any final closing words before folks move on?
Well, folks, what I would suggest, of course, is that if any of you feels that we are looking for people to partner with, because this is not something that can be done by a few individuals, and we are ready to partner with anybody who is looking at these complications, and more so for the time being, the PPH, whether it is in training, either in service or training midwives who are just in school. We are ready to partner with you, and you can use my email, direct email, and my other partners are also ready to partner with you guys. Thank you.
Thank you so very much, Dr. Wanyoro. Thank you to our attendees for joining us. Thank you to Sophia, who is behind the scenes and just shared the link for all of you to return to plenary. Enjoy the rest of the sessions for today. Thanks again.
Thank you.